Good evening, one and all. Today, I'm very happy that I have joined in the WIMS Anesthesia Alumni Academics. I thank Dr. Srinivaslu sir and Dr. Balabhaskar sir for giving me this opportunity. The topic today is management of hypertensive disorders of pregnancy. It's a very complex disorder. Let me cover the topic with the subheadings of introduction, obstetric management, control of convulsions, control of hypertension, fluid management, role of anesthesiologist, anesthetic management by prepartum, intrapartum, and postpartum, and airway management, certain complications with conclusions. It is a complex disorder having 4 to 5 entity itself. As the previous speaker, Dr. Swaminathan said, it has an inconclusive etiology, pathogenesis, and heterogeneity in the clinical presentation. But the management is supportive, and the delivery of the fetus and placenta remains the only definitive cure. The obstetric management, in which the objectives must always be safety of the mother and then the delivery of a mature newborn who will not require intensive and prolonged neonatal care. Multidisciplinary approach along with teamwork, coordinated teamwork with a proper planning and execution would definitely avoid the adverse outcome of maternal and fetal complications. Control of convulsions. The concept of control of convulsions is to prevent the maternal injury, ensure oxygenation, provide cardiorespiratory support, and prevent aspiration. Magnesium sulfate is the cornerstone and a very important drug to manage the pre-eclamptic convulsions. The mechanism is the direct cerebral vasodilatation and relief of vasospasm by NMDA receptor antagonism, and there is an improvement of cerebral blood flow. The magnesium sulfate is given as a loading dose of 4 to 6 grams IV over 20 to 30 minutes, followed by a maintenance infusion of 1 to 2 grams per hour. The infusion is continued well before the delivery and is further continued for 24 hours in the postpartum period. If there is a recurrence of seizure, reload with the 2 grams over 5 to 10 minutes is given. There are other alternative drugs are available. The adverse effect of magnesium is impairs peripheral NM neurotransmission and competitively inhibiting the calcium at the neuromuscular junction. It potentiates and prolongs the action of all muscle relaxants. Respiratory depression, hypertension, cardiac arrest, atonic PPH is all the adverse effect of magnesium. So monitoring is important, including knee-jerk, respiratory rate, SpO2, urine output. Serum magnesium level also to be monitored as the therapeutic window is very narrow. Magnesium sulfate is the established obstetric practice of seizure prophylaxis. You use magnesium intravenously, the toxicity should be expected. The normal range is 4.8 to 8.4 milligram per deciliter. The loss of patellar reflexes, feeling of warmth, flushing, double vision, somnolence, slurred speech, muscular paralysis, respiratory difficulty, and cardiac arrest are the sequence of toxicity. So monitoring becomes important, and whenever the respiratory rate is less than 16 and the urine output is less than 25 ml per hour over the past 4 hours, loss of tendon reflex and recurrent seizures to be considered for toxicity. If suspecting toxicity, if the urine output is less than 100 ml and there is no other clinical signs, decrease the rate to zero point 0.5 grams per hour and review the other management. If petal reflex is absent, stop the max self infusion until the reflex returns. If the respiratory depression is present, stop max self infusion and give oxygen by face mask and place the patient in a recovery position. So patient's impaired conscious level may not affect the aspiration risk. If the respiratory arrest occurs, stop max self, give 10 ml of 10% calcium gluconate over 10 minutes and start positive pressure ventilation after intubation. If cardiac arrest is occurs, commence the CPR, stop max self infusion and give IV calcium gluconate. If the cardiac arrest occurs in the antepartum period, immediate delivery of the fetus is vital. For controlling hypertension, the systolic pressure more than 160 millimeter of mercury and the diastolic blood pressure more than 110 millimeter of mercury are being considered the limit. And with the goal of preventing maternal sequelae, it has to be treated. Yeah, rapid changes in maternal perfusion pressure adversely affect the uteroplacental perfusion and oxygen delivery to the fetus. So, the management should be carefully titrated to avoid abrupt change in maternal blood pressure. Aim of the therapy is to lower the mean arterial pressure no more than 15 to 25% with a target of systolic pressure 1 to 160 and diastolic pressure between 80 and 105. Selection of the drug is based on clinician familiarity and the expected adverse effect. There are certain drugs are to be avoided. The treatment regimen contains labetalol, hydralazine, nifedipine, and nicardipine as first-line treatment. Labetalol is commonly used with a dose of 20 milligram IV bolus and then followed by 40 and 80 every 10 minutes to a maximum dose of 220 milligram. And the onset is 5 to 10 minutes. Hydralazine also being tried, but the reflex tachycardia would be a problem. And nifedipine can be tried orally, but the action is 10 to 20 minutes. Every 20 minutes, the 10 milligram nifedipine could be repeated, but sublingual nifedipine should not be given. Nicardipine, 10 to 15 minutes is the onset time, and that also can be tried. The fluid management in pre-eclamptic patients. The vascular system is a contracted, porous, leaking, underfilled system, which is associated with the intravascular volume depletion. The optimal approach remains controversial. Given the potential dysfunction of pulmonary endothelial glycocalyx and renal glomerular endotheliosis, there is a high possibility for pulmonary edema. There is an oncotic pressure as well as the hydrostatic pressure imbalance also is reason for pulmonary edema. Clinicians should restrict fluids unless monitoring is used. IPP monitoring with or without non-invasive cardiac output monitoring with the TTE will be very useful. Volume expansion is not recommended. Fluid should be limited to 80 ml per hour. In case of hemorrhage, loss should be assessed and replaced appropriately. A fluid challenge with 250 to 500 ml of crystalloid to increase the CVP, but not exceeding 4 to 5 millimeter of mercury should be considered. Any increase above 4 to 5 millimeter of mercury should be avoided. The role of anesthesiologists mainly to help the obstetrician. By means of controlling and preventing the further convulsions, controlling the blood pressure, establish a clear airway, preventing major complications, providing labor analgesia and anesthesia for cesarean sections. Anesthetic management is a highly challengeable one due to a complexity of many problems. The conditions can suddenly deteriorate into hypertensive crisis, pulmonary edema, placental abruption, eclampsia, or health syndrome. It is important to ensure hypertension is well controlled, seizure prophylaxis is initiated, and volume status is optimized. A complete physical examination, including proper airway evaluation, is important, and equipment to manage a difficult airway should be immediately available. A smaller size, 5.5 or 6 size endotracheal tube will be very useful in an edematous severe eclamptic patients. Standard monitoring, radial artery catheter, two free flow IV lines are also very important. Blood and blood products with the cross matched should be kept ready for the immediate requirement. Laboratory investigations includes complete blood count, hemoglobin level, platelet count, LFT, serum, urea creatinine, and urine analysis. Estimation of PT, PTT, fibrinogen levels and INR are needed only in the presence of the admission platelet count less than 100,000 and abnormal liver enzymes, and placental abruption and HELLP syndrome. So the major advantage of neuroaxial blockade are control of hypertension and avoidance of the need for airway management. Platelet count of 100,000 is considered adequate for safe administration of the blockade. When the platelet count decreases below 75, other tests also become abnormal. So, fortunately, epidural hematoma is a rare complication in obstetric population. Serial estimation of platelet count and platelet function has to be monitored, and the route of delivery is one of the important factor to decide the mode of anesthesia. Anesthesia for labor and vaginal delivery by means of epidural anesthesia is an eminently suitable one. The commonly used local anesthetics are bupivacaine, levobupivacaine, ropivacaine with adjuvants. With careful fluid administration and slow induction of the block, the hemodynamic remains stable with a little, if any, changes in the hemodynamics. Techniques of labor epidural analgesia is standard monitoring with ECG, SpO2, BP, and fetal heart rate. Oxygen administration is important. After placing the epidural catheter in routine manner, 10 ml of bupivacaine of 0.125% mixed with fentanyl 2 mg or 0.2% plain ropivacaine as a loading dose, followed by epidural infusion will give an excellent analgesia with minimal motor blockade. And alternatively, patient control epidural anesthesia could be tried. Nowadays, prophylactic epidural catheter placement in early labor in all high-risk patients, including those with severe eclampsia. The goal is to avoid GA. Whenever you put a prophylactic epidural catheter, the placement should be confirmed with a small dose of local anesthetic to ensure catheter patency. Anesthesia for cesarean delivery, uh, RA, regional anesthesia, the method of choice. Conventional epidural, single shot spinal, combined spinal epidurals are techniques. Stress-related hormones such as ACTH, cortisol, catecholamine levels are remain stable whenever you plan for regional techniques. Hypotension and use of vasopressors. Hypotension is very commonly come across, and among the vasopressors, ephedrine is preferred. Phenylephrine could be tried in patients who is having a heart rate of more than 120 per minute. General anesthesia is planned whenever the patient has a refusal for regional techniques, emergency cesarean delivery for fetal bradycardia, coagulopathy, hypovolemia from severe hemorrhage, inability to site the epidural due to the anatomical problems, or any surgery in the back region. Reflex tachycardia and severe hypertension, as well as the possibility of a very difficult tracheal intubations, are important complications with general anesthesia. Laryngoscopy, intubation, extubation, all can trigger a severe hypertensive response that can be managed with the IV labetalol, esmolol, fentanyl, or NTG. General anesthesia is the choice in unconscious attended patients with evidence of increased ICP. Anesthesia is achieved with the opioids and relaxant techniques, and deliberate hyperventilation is done. There are certain important considerations to be followed is in as there is a risk of airway edema, possibility of difficult airway. Although the cholinesterase level is decreased, that will not affect the action of duration of action of succinylcholine and other ester local anesthetics. Exaggerated hypertensive responses to endotracheal intubations are expected. Drug interaction between magnesium and muscle relaxants are anticipated. A small dose of volatile would help to prevent the awareness. Extubation done in the left lateral position when the patient is fully conscious, else patient can be transferred to ICU for ventilator support depending on the preoperative condition and intraoperative behaviors. HELLP syndrome is one of the worst complications. The clinical presentation with the HELLP syndrome is highly variable. Hypertension may be absent in 20%. The criteria for HELLP syndrome is hemolysis, elevated liver enzyme, and low platelets, along with abnormal peripheral smear, and total bilirubin may be more than 1.2 milligram, and serum AST will be more than 70 units per liter, and the platelet count may be less than 100 per microliter. The very close differential diagnosis would be acute fatty liver of pregnancy, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome. The patient should be carefully taken care in the tertiary care centers. Immediate delivery should be performed in patients more than 34 weeks. Less than 34 weeks means without proven lung maturity, corticosteroids should be given and delivery should be planned within 48 hours. The conservative management and expectant management poses significant risk and is not warranted. Patients with favorable cervix should be allowed for trial labor. And operative delivery may be harmful. Intraoperative considerations should include drain placement in subfacial, subcutaneous, or both due to generalized oozing. A potential life-threatening complication of HELLP syndrome is subcapsular liver hematoma, which causes a high mortality. Confirmation of diagnosis by CT scan, ultrasound, and MRI could be very much useful, and patient may presented with the epigastric right hypochondrial pain or shoulder pain. Anesthetic management is similar to patients with severe preeclampsia. The major difference is rapidly deteriorating coagulation status. The entire coagulation panel of tests should be obtained before neuroxyl blockade. For patients with the platelet count less than 50,000, platelet transfusions are indicated, especially before cesarean delivery. General anesthesia is the safer option for such patients. Massive transfusion protocol should be followed and should be prepared for in the HELLP syndrome patients. Eclampsia is another important complications. The symptoms prior to seizure activity include severe persistent headache, blurred vision, photophobia, epigastric pain, nausea and vomiting, transient mental status changes. The steps unique to a seizure in a parturient includes airlift urine displacement to prevent aortic cable compression. Control of BP and control of CSAR are the very next important steps to be taken. Facilitation of delivery of the baby within 24 hours is important, and vaginal delivery is preferred. Cesarean deliveries are performed for obstetric indications only. Anesthetic management principles are same for severe preeclampsia. Eclampsia, most of the time, the patients are becoming post-ictal cloudy consciousness. So airway, breathing, circulation has to be taken care of. The drugs used in eclampsia is discussed already. To conclude, hypertensive disorders of pregnancy are major contributor and leading cause for maternal and fetal morbidity and mortality worldwide. Etiology is unknown, and the delivery of the fetus is the only effective cure. The goals of treatment are prevention of seizures, control of hypertension, and optimization of intravascular volume status. Anesthetic management is a real challenge because the presence of concurrent medical and obstetric problems. Complications of preeclampsia such as pulmonary edema, eclampsia, HELP syndrome, placental abruption may occur, adding to the complexity of problem. Regional anesthesia is the method of choice for labor pain relief as well as cesarean delivery due to the overwhelming evidence of maternal and fetal safety compared with the other anesthetic techniques. These are all my references. Thank you.